So without further ado, let's warmly welcome Dr. Pang to take the stage.
This is one of your take-home slides in a sense. So we're talking about CT, MRI, and ultrasound. CT is incredibly fast study, very available. Almost every institution have 24/7 service. However, it's definitely have radiation. Okay, it's a very fast study. So what do we mean by fast? It means that it's somewhere around 3 to 10 seconds. It's a scan time. Getting the patient ready, taking the patient off the table, that's a different consideration. It typically does not require sedation, okay? But of course, it has radiation. MRI, on the contrast, does not have radiation. However, it takes much longer. What does much longer mean? The shortest study is somewhere around 20 to 30 minutes. So in comparison to a few seconds on the scanner, that's incredible difference. For that reason, if your patient is in great pain, it's like altered mental status or pediatric patient, they will require sedation. Sedation has its own risk that, again, if you're an anesthesiologist, you can talk more about it, but that's something to be aware if you want to order it in that kind of scenario. It is really great for brain, spine, and soft tissue. That's including musculoskeletal system. Okay, we're not talking about the bone, we're talking about the cartilage and all the joint stuff. So it is really useless for lung as an organ altogether. Now, ultrasound is this in-between structure. It is no radiation and almost never needs sedation. It is the best part, it is real time, like you're scanning the patient in front of you with the image in front of you. For some in country, for example, for China, our sonographers are actually doctors, so they're incredible. The result is also incredible. In the United States, though, most of the sonographers are actually technologists, so they're not doctors. So we, the radiologists, get the picture from the sonographer, not able to really say, I want to see this and that in different way. So sometimes the study is very operator dependent in this country. As a pediatric radiologist, we actually go scan patient quite frequently. So that's a little bit different scenario. Ultrasound has no radiation, real time, very available, and excellent for superficial structures. Okay, so that's your first take-home message. We're going to re-emphasize this throughout the lecture. So let's talk X-ray. It remains to be the workhorse for inpatient or outpatient setting. It is excellent for anything that's really, really loosened than the lung. It's excellent for anything that's super dense, especially when you're looking at the lung as the background. It remains super relevant in the MSK evaluation. Please order multiple view if you're looking at bone, especially the peripheral bone. Please give relevant history so that your radiologist can help you. Sometimes the subtle finding is only prompted by looking at that area much more carefully because your clinician said it's the third finger. So radiation exposure is minimal. We talked about it a little bit. Most of the time, the benefit outweighs the harm. Please explain to your patients so that we can all do the right thing. Okay, so now we're going to leave X-ray and we're going to talk about ultrasound. Ultrasound is wonderful for many things. It has no radiation. It's a real-time visualization. It is absolutely wonderful for procedure guidance for the real-time visualization. We do breast ultrasound biopsy every single day. It is much more available these days, particularly bedside applications. So a lot of ER, a lot of units are using ultrasound on the bedside. It is also really great for superficial stuff, or sometimes it's the best thing as a first look because it's quick, no radiation, it's available. What's so not great about it? We talked about it, it's operator dependent, but you cannot see through the bone with ultrasound. So anything with underneath the bone, forget about ultrasound, you can't see it. You cannot see through the air. It's enough so-called dirty shadowing that there's nothing underneath that become a reliable diagnosis. It loses resolution the deeper you go into the body. And unfortunately, we do have a body habitus issue these days. So, really big patients, sometimes we just can't see very well. And of course, it's operator dependent. There's a whole list of ultrasound I listed here. Let's now go through each time. It's contrast, one-to-order contrast. You can categorically think about when you're in the category of rule out pathology, wherever that is, you are going to order IV contrast. It doesn't matter if you're looking for tumor, infection, abscess, or lymph node. As long as you're looking for this kind of pathology, you want CT, abdomen, pelvis, chest, abdomen, pelvis, neck, chest, abdomen, pelvis with contrast. Do you need PO contrast? Sometimes, most of the time we will like it because you will see better, you will see the bowel better with PO contrast. In emergency, it is okay to skip PO contrast. It's a lot to drink, it takes some time. In the acute setting, you can ignore the PO contrast. So in general, the majority, the workhorse is CT, IV, and PO contrast. PO can be ignored in acute setting, but IV contrast. If you ever want to do angiogram, you must have IV contrast. When do you do non-contrast? These are the common ones. All of you guys probably ordered it. CT of the head, non-contrast, rule out hemorrhage. Give contrast, make this diagnosis difficult. Non-contrast. CT of the lung, looking for lung nodule, lung mass, pneumonia, pneumothorax. With and without contrast, CT of the lung looks similar for radiologists. It's just a windowing. You do not need that IV access, IV pole, difficult IV access, and contrast badness associated with contrast for if you only worry about lung cancer, CT, lung, non-contrast. CTKUB, rule out renal calculus hydronephrosis. I think all of you guys probably ordered that. You do not need contrast for that, actually making the visualization of renal calculus much harder if you give contrast. However, majority of the situation, take-home message, is CT with IV contrast and ideally with PO contrast as well. Do you ever order CT with and without contrast? Yes. There are particular situations, especially you already know there's a mass, we're evaluating it. If it's an aneurysm, we want to know if there's mural hematoma. If it's a dissection, we want to know if the hematoma is there. You may order with and without. This is a much less clinical scenario for you to do. This is your real workhorse. Apply for majority of the situation. So take-home message is, if you can't remember anything, if you order this, you are 80 to 90% of the time you're getting the right study. So that's contrast, definitely have renal toxicity. So aggressive hydration, as an outpatient, just drink more fluid. Inpatient, IV fluid. If the patient's already in renal failure on dialysis, then there's no more concern because you're anuric and you're on dialysis already. Do the study, dialysis after, no problem, no additional injury. If you're teeter about that, like I'm just about getting into the renal failure to go on dialysis, but I'm not, this is the tricky situation. Now it is all our job, yours and mine, to figure out, really, do you need a study? Can we do anything else? Replacing the CT contrast study. So again, that's case by case. The GFR cutoff has dropped to 30. I love to say the 40 is the new 30, 50 is the new 40 as we all get older. It's been dropped to 30, so a lot more leeway to do that. This hyperthyroidism is incredibly rare. I've never seen one. I've been a radiologist for a very long time. Now, the other component, allergy, is also a real concern. So talking point, again, if you have a history or patient have a history of asthma, it does increase the likelihood of an allergic-like reaction, for sure. If patient has unrelated allergy, it's about 2 to 3-fold increased risk to get a contrast allergic reaction. That's include the most mild version or the anaphylactic reaction. There is no cross reaction between CT contrast and MRI contrast. So it does not matter what had happened to them on the other side, okay? Shellfish, a common thing. I'm allergic to shrimp, I'm allergic to shellfish, has no relationship of allergy, does not change the risk of allergic reaction to the CT contrast. So that's allergy. Documentation is important, no matter for you or for me. If the patient the first time getting a CT, getting allergy documented, otherwise we wouldn't know, right? You wouldn't know. Patient goes to different hospital. Now, if you do have allergic reaction, does not stop you from doing a CT contrast. You can do pre-treatment, especially when they're not life-threatening allergy. This is the normal outpatient plan. You can find this on Google, so no need to try to remember them. I don't even try to remember it. And this is the faster way. If the patient is urgent and they really had a pretty significant allergic reaction, but we really need CT contrast, nothing else can replace that, you can do Solu-Medrol. Even if you give one dose in, this is 12-hour and 2-hour prior to study. Even if you need it right away, give one dose, it's still better than none. But you just have to be very cautious about observing the patient afterwards. Typically, these are ER and inpatient, so we have team observing them. So these are what you tell patients and what you do when there's an allergy. Okay, now next thing is Re-summarizing CT, we're going to be done with CT very soon. So the common non-contrast CT you will ever order, CT head neural hemorrhage, trauma, any of the bone stuff. If you're thinking about sinusitis, you do not need contrast. CT sinus without contrast. CT temporal bone looking for inner ear structure, otosclerosis, all of that, non-contrast. CT lung, unless you worry about mediastinum, non-contrast. All the low-dose CT screener of the lung are non-contrast. CT spine, again, just like bone, non-contrast. CT QUB, rule out renal calculus. Everything else require contrast. And these are some specific one may need with and without contrast, but again, your workhorse is this. No matter coming from which part of the body, it's CT contrast to rule out infection, mass, fluid collection. So that's your another take home. One more thing, limited application for pediatric population because it's radiation. So we do try to use either ultrasound or MRI as alternative. The dose can be adjusted but require discussion with your radiology. CT is highly available, very fast, literally takes less than 10 seconds to scan the patient. There's exceedingly number of protocol to work out what the patient may have. Re-emphasize normal appearance of the kidney and pancreas does not rule out pyelonephritis or pancreatitis. And CT high resolution chest is only for evaluation of interstitial lung disease because this patient is going to be scanned in at least 4 different times. So it's a very high dose CT. It's only to evaluate interstitial lung disease. All your CT scans are high resolution. For 64 slicer, which is common, is 0.625. You have all the same resolution. This name is really a misnomer in the sense it's make people confused about, I want a high resolution CT. This is much higher radiation, not for everybody. Most people are just CT equally resolution. MRI itself is going to be a completely different subject by itself because it's so complicated. But I want to just mention a few things. Brain, extensive application. Spine, extensive application. Anything that's soft tissue, anything that's MSK, extensive application. You can do angiogram, venogram. You can do them with or without contrast. Their technique to do angiogram, venogram without contrast, which is wonderful. It's great for fetus, non-radiation. It's great for female pelvis. There are numerous contrasts developed in history. At this point, your facility is probably using a gadolinium-based macrocytic linear non-ionized contrast, which is a pretty safe contrast. So the NSF risk is much, much lower. It's really pretty good and pretty safe. There are more than one contrast though, other than the gadol-based contrast. Eovis, for example, is a commonly used liver agent. It's a hepatobiliary agent. It's again, troubleshooting for a liver tumor, hopefully can avoid a biopsy if we can figure it out. You do not give contrast to pregnant female, no matter how safe it is. There are still safety concerns, which is gadol deposition in the fetus or even in adult, but more so in fetus. So we do not give contrast to pregnancy, okay? There are extensive post-processing power. Every day there's something new coming up. And again, these are the best sort of like application for MRI. So some example, because we're never going to be able to talk about all MRI. This is a DTI study. This is MRI of the hand. This is MRI CP, MRI of the fetus, MRI of the angiogram, and MRI of the prostate. A lot of details to talk about in each different category. So a few other common scenario that we want to touch on before we have to finish. If you have a patient coming with a headache, the first line is typically CT non-contrast to rule out hemorrhage because what's your concern? Hemorrhage is the biggest concern. You may also have stroke, trauma, tumor, MS, all of these things. But hemorrhage is the biggest concern because if you're even having underlying stroke with hemorrhage, the treatment is entirely different. First line, CT non-contrast. If you find something, you may go to MRI to further characterize to figure out what's going on. MRI non-contrast for any urgent cases. Kind of giving you a good idea already without the contrast. With contrast, just even better evaluation. So last words, pregnancy. Do not ever use CT unless it's life-threatening. Even for women, young women who may not even have known pregnancy, that should be a question asked. Could you be possibly pregnant? Let's do a pregnancy test before we scan you, okay? They do not ever receive MRI contrast. They can receive CT contrast, okay, but they don't typically get CT anyway. We can actually rule out appendicitis on the MRI. It's just not that widespread because MRI is not that available for every institution to do this all day long. Okay, so fetal MRI is excellent. We do this day in and day out to look for fetal structure abnormality like this poor baby. So pregnancy, no CT unless life-threatening. Do not give IV contrast for MRI. Okay, so that's conclude my talk, hopefully not too late. And truthfully and sincerely, the studies are just different. They are not necessarily better or worse. In the right situation, the cheapest study may be the best study.